I'd like to welcome Mr. Jean to give us an introduction, and then welcome Dr. Mugabe Christian to take us through the course on COVID tracing and on contact tracing. Thank you.
Thank you very much, Alan. My name is Jean Damascene. I'm among the organizers of the event. To remind people, participants who come to this event for the first time, maybe, this is...
Welcome Mr. Jean to give us an introduction, and then welcome Dr. Mugabe Christian to take us through this.
Yes, the event is organized by Rwanda Healthcare Federation, and this is part of the activities that are being done by Rwanda Healthcare Federation to respond to COVID-19 and to strengthen and increase skills in private health sector. And this is one of the activity, training of health professionals. We are undertaking some other activities like a research project that's being done on assessing the preparedness and response of private health facilities towards COVID-19. And this is an activity that's being done throughout all countries of East Africa. It's being done in Kenya, Uganda, Tanzania, Rwanda, Burundi. And we are working on that. To remind some of you that Rwanda Healthcare Federation is part of the East Africa Healthcare Federation. Other countries' federation like Kenya, Uganda, they also have other activities that they're working on, and this activity is shared. So that's it. So we had session 1 with the introduction and background on COVID-19. We had as well the management. Today we have the contact tracing, and tomorrow we will have the vaccine, trends on the vaccine. How is this vaccine made? How is it? How can you trust it? And how can we sensitize the population when it's ready? And all about that. So we're going to be covered tomorrow by Dr. Daisy. Today with Dr. Mugabe, we have the contact tracing. So if Mugabe has joined, maybe he can take from there and keep going. Thank you very much.
Thank you very much, Mutoni and Mr. Jean Damascene for this opportunity to be sharing on contact tracing for COVID-19. I prepared a PowerPoint that I will be using. I don't know if I can share my screen. Yes.
Sure.
All right. So my name is Mugabe Christian, and I'm going to be facilitating about an hour the guidance on contact tracing for COVID-19 pandemic. But before we begin, I would like to introduce myself, mostly on my journey on support of COVID-19 under the Rwanda Joint Task Force for COVID-19. So I think if I'm not mistaken, the first COVID-19 patient was identified in Rwanda on 14th of March, 2020. And on the 25th of March, I was reached out to give support in the treatment center of Kenya. I spent, I think, 4 days. And then I was moved to Nyamata. It was an isolation site, and transforming it into a treatment center. I spent a week there. And then again, I was moved to Masoro isolation site. I was there for a period of 3 months. And later, the Masoro isolation site became a transit site. We were receiving truck drivers from DRC, Congo, Kenya, Tanzania, and Burundi, and Uganda. And later, the Masoro transit site was shifted to Rebero, but it continued to be a transit site. And it was, And then in September, I left the Joint Task Force of COVID-19 working on other areas of my life. But when I was called, when I was contacted to give guidance on contact tracing, I was happy because it would give me a platform to share my experience, and also some of the readings I've been, some of the materials I've been reading, that at the end of the presentation, I will share if you're interested in going deeper to know about contact tracing, how it's done, and why in certain places it's not being done. Yeah. So basically, in this presentation, yes.
Sorry to interrupt, Doctor.
Yes.
Could you please? There's an issue with your sound breaking, and so the
Okay.
participants are not able to hear you very well.
I have increased my volume. Just let me know if it is still the problem.
You're now loud and clear. Thank you.
All right, thank you. So in this presentation, I'm going to basically take you through the meaning of, who is a contact? What does it mean to do contact tracing? And what COVID-19 characteristics that affect contact tracing and management of contacts? And then what are some of the strategies that are being used to adapt on these challenges, mostly in this changing epidemic. And then I will dive deeper into the two strategies, the containment and the delay and the mitigation. I also look at, you will notice that contact tracing is very resourceful. And so it's better to prioritize contacts and for better evaluation and monitoring. So I will also dive deeper into the 4 priorities and who belongs to what priority. And then I will go deeper into highlighting on the steps involved when you're conducting contact tracing, mostly contact identification, contact listing, contact follow-up, and contact discharge. And then I will do I will show you how they do contact tracing flow, but then I will highlight mostly on the 4 aspects: the rapid notification exposure, the contact interview, medical monitoring, and contact closeout. And then what are the best practices for managing contact? Yeah, this is going to be my outline, and at the end of the presentation, I will accept questions, and while I'm presenting, you can type the questions so that as I highlight on these things, when I reach on the question, I can try to answer it as I move forward. Before we begin, there is an animation video on contact tracing by the WHO that I would love to share. But yes.
COVID-19 continues to spread around the globe. You can help stop COVID-19 by participating in contact tracing. How does contact tracing work? Contact tracing is a system that has been used for decades to stop infectious diseases. A contact is anyone who has had direct physical contact or was within 1 meter for at least 15 minutes with an infected person, even if that person does not have symptoms. This applies to anyone who has had contact from 2 days before a person gets sick until 14 days afterwards, or from the 14 days when an asymptomatic case tested positive. Once you are confirmed as a contact, you will be asked to go into quarantine, which means to separate yourself from others and to monitor your health for any signs of illness. The monitoring ends on the 14th day from your last contact with the person infected with COVID-19. Quarantine can take place in a special facility outside of your home or at home if you can stay separated from family members. Why 14 days of quarantine? It can take from 1 to 14 days from contact with the virus to develop symptoms. During this time, you should stay in quarantine and monitor symptoms and follow instructions given to you if you become symptomatic. Without contact tracing and quarantine, the virus will continue to spread. This leads to more people becoming sick and infecting the most vulnerable. By identifying and limiting contacts of people infected with COVID-19, the virus stops spreading and the community stays safe. To break the chains of transmission, we all need to work together. If you become sick with COVID-19, stay away from others. Follow the recommendations of your medical care provider and share the list of people who you came in close contact with. With your help, we can prevent further spread of the virus and save more people's lives. By acting together, we can break the chains of COVID-19 transmission. COVID-19.
So basically, like in the video, it defines who is a contact and why, what is contact tracing, and why basically the 14 days, and what do you do when they're doing contact tracing. So when they're doing contact tracing, you stay isolated in so you don't meet people to avoid the spread. In this way, you're cutting ties with the outside people and you're protecting them. And basically, in this PowerPoint presentation, this is what I'll be referring to over and over again. So to give more light, a contact is a person who has experienced some of these exposures. You know, so if a person has come face to face with a person who has been probable or confirmed case of COVID-19 in a distance of 1 meter for a period of 15 minutes, that person is classified as a contact. If a person has come to any direct physical contact with a confirmed case, now this time it's not a 1 meter distance, but he has had a physical contact with a confirmed case, also this is a contact person. Then if a person is taking care of a patient who has been confirmed of COVID-19 without using proper personal protective equipment, for example, face mask, gloves, and other protective equipment, also this person is regarded as a contact. Also, in situation where you are in a, when they do risk assessment of situations and they find you've been in a closed environment with a positive confirmed case, for example, you are in a classroom, you're in a place of worship, in the hospital's waiting room, or you're in a shared transport, also you are considered as a contact. So every time we are saying contact, this is the person who meets these 4 criteria. And the contact tracing is a process of identifying persons who have come into contact with a person that has been confirmed as a positive case, and then collecting further information about these people. That's the short description of contact tracing. And then COVID-19 has characteristics that affect contact tracing and management of contacts. One is that COVID-19 is transmitted primarily through droplets with a dispersed measure of 1 meter. You know, so like you can imagine the people you meet if you put a 1 meter distance, the people you meet, you know, in that 1 meter distance. This is one characteristic that affects the contact tracing. Then the other thing is that most people begin to have symptoms of COVID-19 on day 2 to day 14, and so like it's very hard to basically know to pinpoint a person that you got infected from, because by the time you have symptoms, that means you have to go back the first 2 days, and it might be very hard when you've lost track of where you've been or people you've been meeting. And then the other hindrance is that people the people can be infected, but they have no symptoms, you know, and this is also another challenge, that up to date there is little evidence that asymptomatic people can transmit the virus, but until this possibility, should be considered until there's clear evidence that a person who is asymptomatic can actually be infectious. And then COVID-19, when it is presenting itself, it presents itself with mild symptoms of flu and cough. And people might neglect these symptoms and they still continue on their daily activities visiting friends and family members, going to work, going to the hospital. And the more they do this, they are infecting more and more people. So like when you look at these challenges and the characteristics of COVID-19, it makes contact tracing and contact management a bit hard. But there's been strategies for contact tracing that have been adopted. For example, for COVID-19, it is recommended that all close contacts of confirmed cases should be traced in the early days of the epidemic. But so this sentence means as long as you've gotten your first case of COVID-19 in an area, you should begin the immediate contact tracing. But because there is a speed in the transmission of COVID-19, the number of contacts required to follow up can increase rapidly. So like you've noticed, one confirmed case of COVID-19 becomes 4, becomes 8, becomes like the number increases spontaneously, rapidly. So it becomes very, very hard, and also it requires a lot of resources. That at a certain point you might no longer find contact tracing contributing enough to effective epidemic control to justify the resources that are being required. So, for example, most like attempting to maintain follow-up of all these contacts can jeopardize the quality and of contact follow-up and the diversion of resources away from the intervention. So at this stage, it's better to have contact tracing and you look at other interventions. Now, when you say other interventions, they are broadly divided into two. We have containment and delay and mitigation. Containment is a strategy that aims at stopping the disease and limiting the duration of the outbreak. So usually what happens here is that you immediately find cases and you isolate them as early as possible. And then when you find these cases, you begin identifying the contacts. And this is where you do mostly contact tracing. And then for the delay and the mitigation strategy, this is when the transmission like the numbers are very many, and your main aim is to slow the transmission and reduce the burden on health services. Because as much as there is an epidemic on, we also have other diseases. Expectant mothers have to go to deliver. Malaria cases are still there. A lot of patients still have are being followed up for tuberculosis and other infections. So when the number of of epidemic exceeds, it puts a lot of burden on the health services. So by the time it reaches this stage, you want to delay and mitigate the transmission, and this is done by using social distancing. Remember, I spoke about that the COVID-19 is spread through droplets by 1 meter. So when you do social distancing, you're trying to delay, and then also a lockdown. A lockdown helps a lot because it puts people in single places, and you delay the transmission, or you reduce the transmission. Now, you have to know that not all contacts, but by this second strategy, not all contacts can be identified and traced. So the focus of the contact tracing shifts to where the effect will be greatest. An example, it can shift among the more vulnerable groups, or to newly affected areas, or to specific clusters where containment is still might still be possible. Now, apart from this, there are 4 main phases that you would use, and then depending on the phase, you would know which strategy to use. Now, there are 5 phases, and there's where there is no reported case of the disease in the country. There's where there is an imported case, but with limited transmission. So like you've gotten a case that has been imported in the nation, but there's very limited local transmission. And then there is also increased imported, and also there is local transmission, but still you can link to known chains of infection. If these there are local transmissions, but you can exactly tell these local transmissions came from this particular case. And then there's also when the epidemic is widespread in the community, you know. So going through the 4 stages and how you do contact trace or how do you prepare is, for example, in the first phase where there is no COVID-19 case, and that means there's no reported case in the country, the best thing you can do is to sensitize the population to the idea of the outbreak, and you do outbreak control measures, including contact tracing, quarantine, individual and community social distancing before there's a case. And in the early stage of the outbreak, what you do is, this is when you have 1 or more imported cases, but there is limited local transmissions related to the imported cases. Now here, what you do, you conduct contact tracing, and I will go in the details on how you do contact tracing, mostly when you're in the first phase. And then in the second phase is when the outbreak is actually expanding. Now there are increased numbers of imported cases, and also there is increased local spread, but all the local cases can be linked to a non-transmission chain, you know. And then there's also outbreak of clusters, but with non-common exposures, you know. An example. No, let me not go into examples. I would love you to think of the example, for example, in the second phase, you know, where there are outbreak clusters, but with non-common exposure. So when you're in the second phase, the best thing you can do is you contain and slow transmission. Like you intensify contact tracing, and you begin and you intensify adherence to quarantine as much as possible, you know. And then if resources reach its limit, you begin prioritizing contact follow-up. Mostly contact follow-up who are on the highest risk exposure, you know. And then on the third phase, this is when the outbreak has advanced. Now, on this, yes. If there's a question. Okay.
No, go ahead. Please go ahead.
If for example, on phase 3, this is when the outbreak has expanded, and here you begin to look at a localized outbreak. They begin to merge, and there is 1 or more cases of death that are occurring outside the non-transmission chains. And then another thing is that you find transmission is happening in multiple generations in the transmission chain. For example, you can get someone who is a teenager, you can get a young adult, you can also get an elderly, and they're all transmitting. This is when you know you've reached an advanced, the third stage, advanced outbreak. And also, cases are detected among severe acute respiratory illnesses, but they don't know when they got exposed. So by this stage, you have contact tracing in all outbreak areas, and then you go to the other strategy of delay and mitigation. You know, and that's when you do lockdown. You put 1 meter distance among the general population, and then the fourth stage, that's a larger outbreak with nationwide transmission. This is when, for example, in Rwanda, you find everywhere you go in each district, in each province, the transmission has spread all or nearly in all the country. So by this time also, you have the tracing activities, and you follow you follow the delay and mitigation, mitigation. So basically, in my presentation, I will focus mostly on phase 1 and phase 2, and And then for phase 3 and phase 4, when there's a lockdown and social distancing, I will not go deeper into that. And then, like I've mentioned, contact tracing is it takes a lot of resources, and at a certain point may no longer contribute enough to the effectiveness or to the effective epidemic control to justify the resources required. So therefore, attempting to maintain follow-up of all contacts can jeopardize the quality of control, contact follow-up, and divert resources away from other interventions that might be important. So this is why they prioritize the people in 4 priority classes for easier evaluation and monitoring. So, for example, hospitalized patients, healthcare personnel, and first respondents, an example are law enforcement and firefighters, individuals living, working, or visiting acute care facilities, for example, like mental health facilities and long-term care facilities. Like long-term care facilities are these facilities that take care of the elderly or people with disability. And then also individuals living and working or visiting community congregations. Community congregated settings like prisons, homeless shelters, education institutions, workplaces, and also members that have a large family, but they are living in a very closed quarter, a small house, but the members in the house are many, and also individuals who live in household with a high-risk individual, or who provide care in a household with a high-risk individual. All these people are in priority 1 because they have they might have a lot of contacts with a confirmed COVID-19 patient unknowingly, and they might do it over and over and over again. That's why they put them in priority 1. And this helps in evaluating and monitoring contacts. The people belong to priority 2 are workers in critical infrastructure. Critical infrastructure, these are the people you find in transportation, you find in food services. For example, in hotels and restaurants. They may not have constant contact with a confirmed COVID-19 patient, but it's very likely that in their daily hustles, they will meet a confirmed COVID-19 patient. Also, individuals who are above the age of 65 years and older, individuals at high risk of severe respiratory diseases, and also pregnant mothers. All these belong to priority 2. So it's also better to know this priority so that when you're giving resources, you know how to monitor and evaluate. The people belong to priority 3 are individuals with symptoms, but who do not meet any of the above categories. And people with who are in priority 4 are individuals without symptoms and who do not meet the above categories. Now, so once now when you're beginning to do contact tracing, it's very important that you follow these 4 key steps. And the first step, you identify a contact. So you identifying a contact involves case investigation. Now, to identify all persons that have had a kind of contact with a confirmed case. So you have to know that there is a possibility that a person who has had a kind of contact with a confirmed case might be infected with the virus, and this person may not have symptoms, but if they have symptoms, then you have to ask them 2 days before they develop the symptoms. Like I mentioned earlier, a person can have COVID-19 and they can spend about 2 days without having any symptom and might develop the symptoms later. And that's why it was one of the challenges of characteristics of COVID-19, because by this stage, you think you don't don't have COVID-19 because you don't have any symptoms. Now, once you've identified these contacts, then you begin listing the contacts. And this involves registering all persons who are considered to have had contact with a confirmed case. And then after you've listed the contacts, you do the follow-up with the contacts. And then you can either do active or passive follow-up or passive monitoring. So passive monitoring involves providing information on recommendations, such as what to do if you are well. I think if you watch the Rwanda TV, you would see so many recommendations, mostly in between news breaks, of what to do if you're feeling unwell. Hotline numbers to call, and then active monitoring involves requesting their health status regularly. They can do it through a text or a phone call, and then this requires a relationship of trust between the contact and the tracer. And then when do you discharge a contact? So after the 14-day period, these are the 4 criteria that you can use to discharge a contact. One is if a contact has finished his or her 14 days of follow-up period, and if you do a COVID-19 test, the person is negative, or the person has finished his or her 14 days follow-up period, and the person has no symptom of COVID-19. By this time, you discharge this contact. He's no longer contact. The person can also be discharged as a contact if he has tested positive. So if you've been tested positive, you're no longer a contact. You're now a case. And then the other one is if the investigation leads that the person has been reclassified as a non-contact, or the investigation lead that the case has been reclassified as a non-case. To highlight more on this is sometimes they would say you've contacted someone who had who tested positive of COVID-19 test, so that we are going to follow you for 14 days and you request to go in isolation or quarantine, self-isolation or home quarantine for a period of 14 days. But as the investigation leads, they find the person that was linked to was a case is not a case, has been reclassified as a non-case. So by this time, you're no longer a contact. It was a mistake. So by this time, you're discharged as a contact. Now, this is a follow-up plan. This is a flow of contact tracing. So the first thing that happens is that the tracer would call the person, like you've had a contact with a positive, confirmed positive COVID-19, and then now this positive confirmed patient will provide contacts of the person, of the people he or she has met in the previous 2 weeks or 2 days before symptoms started, and then 2 days before the symptoms started, and then till to when they confirm that it's positive, and then they will collect all these contacts, and then there's going to be a contact triage for assignment. So these contacts will be given to tracers, and now the tracers will begin calling the people who were on the list, and then basically the tracer asks them to self-isolate and quarantine themselves. So by this period, the contact might decide to test if the test is available, and the test might become positive or negative. If the test is positive, then the contact does not becomes a case, and then goes for treatment. And if a person is if the contact is negative, it does not mean that this person does not have COVID-19. He or she has to continue self-quarantine and self-isolation for a period of 14 days, and then if this contact finds it begin developing medical problems, then the tracer can direct him to a medical provider. Sometimes, as you notice, is when they tell you to do self-isolation, self-quarantine, most times they're not ready, and they support that that you need. So most times the contact will tell the tracer, this is ABC that I need, and the tracer will find ways, these things with which the contact person. Now, after 14 days of self-quarantine and self-isolation, you do a test. And if a person is tested negative, after these 14 days, then this person gets discharged or discontinued from being a contact. Yeah, and if the person tests positive after 14 days, then the person is no longer a contact, it's a case. And this is basically the contact tracing workflow. But I would like to highlight a few of the steps deeper. For example, the rapid notification of exposure. So basically, when a contact, when a person has been confirmed to have COVID-19 and is asked for people he's met in the past 24 hours or 48 hours, and then you are called as a contact. Like one thing as a tracer you should do, you should never identify the patient, even if this information is asked explicitly by the contact. You should still maintain secrecy of who the patient is, unless if the patient himself begins calling out these contacts and telling them that you shouldn't basically say the patient is this, that's why you're calling them. No. And then you should usually you use phones, text, email, and you try to avoid in-person meeting, because if you do in-person meeting, you're also being a contact, yet you're supposed to be helping out. So you try as much as possible to avoid in-person meeting and use other channels. Phone, you can use a text, you can use an email, you can use a video call, and it's very important that you use the primary language of the individual. And I think there have been protocols that have been put in place for people who are deaf and people who have hearing loss. And again, to emphasize, every effort should be made to reach the contact remotely before attempting in-person communication. Now, when you're doing a contact interview, again, try as much as possible to use the individual's primary language. Try as much as possible to first use telephones and text and video conferences instead of using in person. And you can use in person if the rest of the efforts that were supposed to be made have failed. That's when you can try to use in person, and you have to use protective gears so that you don't become contact yourself. Now, you have to know that any contact who has not been diagnosed with COVID-19 in the past 90 days, even if this person has no symptoms or has symptoms, is supposed to do self-quarantine for 14 days. Now, the best way to protect yourself and others is to stay at home for 14 days. If you think you've been exposed to COVID-19, the best way is to stay home for 14 days. And then you let the tracers, if you have a question, you can always call the tracer and tell him this is happening, how can I get support? And then they try as much as possible to find you that support. The moment they call you that you are a contact, the other best thing is to postpone every plan you had that involves social gathering, vacations, or other planned travels until you've been cleared and you've been discharged as a contact. Now, basically, considerations must be made, for contacts who express fear of abuse or violence, mostly if they are self-quarantined at home. There are special considerations that can be made. So additionally, some contacts, for example, single parents, mothers who are nursing, parents with children and toddlers, and primary caregivers. Also, there is a special consideration that can be made because they face challenges. They have such as child care. They are depending on adult care. So, and this might affect their ability to self-quarantine. So, social services, housing, and other supportive services would be needed for such people who are unable to separate themselves from others in the current living situation. And during self-quarantine, they monitor COVID-19 symptoms. So you have to do daily monitoring of the temperature, every day, and you have specific hours to report. And if you have symptoms, you can have access to the health services. These are health services that are offered online. Yes. Then medical monitoring. So if a contact has agreed to self-quarantine, so he will ideally receive active daily monitoring through real-time communication. So they are like check-in sessions to see what's your temperature today. And sometimes they can be given a temperature logbook, and so they can note the temperatures, if they are coughing, how many times are they coughing, if they are developing other symptoms like headache, fever, they note them down. And then people, the health practitioners can use them when they're trying to assess your health. So contacts who develop and report symptoms should be directly linked to clinical care for testing. Yeah. Now, contact goes out. I spoke about it. Is if you've completed your 14 days, or and you've been tested, and if you don't have the disease, you can always close out. And also, if during the investigation they realize that the case has been redefined and is no longer a case, so you're no longer a contact, because you only become a contact when you've had if you've been close with a confirmed case of COVID-19. Now, there are best practices that are being used to manage contacts. The one is home quarantine. So during home quarantine is that these contacts should be requested to separate themselves in their home for a period of 14 days after having contact with a COVID-19 patient. And then if all these household members are contacts, then they're also requested to stay together in their home and interact normally. But if they are household members, they all stay in one single place. Now, so one thing that you have to know is that it is very, very important to protect yourself. So you always have to keep 1 meter distance in the duration of other people you meet. And the thing is, if the healthcare worker is a contact, what do you do? So if a healthcare provider is a contact, because there is limited number of human resource in the healthcare field, and so if one is a health worker, and it can be extremely difficult to quarantine healthcare workers for a period of 14 days. So what they do is that the healthcare worker, they do self-protection, they wear protective gears, and then they keep working and they monitor the symptoms. If symptoms happen, come, then they get tested. It is not good to test a person who is asymptomatic because the tests would only be, we would only show positivity mostly when symptoms are in place. If there are no symptoms, then there's a very high likelihood that even the test will come when it's negative. So if you test when you're asymptomatic, you might, first of all, you might get wrong results because the viral load is still very, very low. And then another thing is that these tests are right now very important in identifying cases. So you're wasting a whole test. Now, when it comes to practical support, certain supplies like food, water should be given. For students who are still going to school, they can even do homeschooling in this period. And social support can also be given, mostly advice on how to safely engage in social and faith activities with affected households. Like when you're doing social distancing and self-quarantine, it is very, very hard if it's your first time to spend 14 days without meeting anyone. So that's why like this social support is very, very important. And then you can also do livelihood constellation, mostly for people are depending on agriculture, like food. If you don't have enough food, you can always provide food for these individuals. And then testing, like I said, should be done to individuals who have symptoms. And if we don't have symptoms, there is no need of testing. And another testing can be done mostly on the 14th day. And if it's negative, that means it can be discharged as a contact. And if it's positive, then you become a case. You're managed as a case. And then healthcare workers with mild signs or symptoms of COVID-19 tested, regardless of whether they have been listed as contacts or no contacts. Because, like I said, they belong to priority 1 and they are always meeting COVID-19 cases. So if they show any symptom of COVID-19, then they should be tested regardless. Then you'll see in the past, we've had a facility quarantine. So even in Rwanda, we established locations where contacts are taken to wait out the 14-day period. But this may be done to save resources and also limit cases because limit resources because fewer staffs are needed to monitor contacts. And also it helps to reinforce quarantine. However, it is some people might have a mental effect on the facility of quarantine, and they outweigh the benefits, because they think maybe this is where the disease is being amplified. Most people have gone to quarantine. So if I'm going to quarantine, it's going to be very hard for me to come out. So they become depressed. So they think maybe it's contributing to the growth of the epidemic. So they have had different detrimental effects on the facility, on the quarantine facility. So and it's being poorly accepted in some communities in other countries. So most people prefer home quarantine to the facility quarantine. Yeah. So thank you so much. And I don't know if there are some questions as I was presenting. Maybe I ask the moderator if there are questions, and then I can try to answer some.
Okay. All right. Thank you so much, Dr. Mugabe Christian. We've really learned a lot from the good presentation that you've done, especially on the animation part, because that's what easily explains everything. So there are some questions. If you could check the document.
Yes.
he shared. There are a few questions and you could answer them. So whoever has a question could put up their hand or write down in the chat box so that the doctor can be able to give
Okay.
answers.
Yes. So the first question, I don't know who asked the question, but it was my question is, why is it that these last months RBC and Stroke Ministry of Health have reduced making contact tracing? And the reason I will go back to these phases of these epidemic phases. Like I mentioned, on the phase 3 and phase 4, that is advancing outbreak and the large outbreak. So in a community, if to explain better, I have to go through the whole phase. So maybe people who joined later can exactly know why we are no longer doing tracing, or maybe tracing is being done in particular areas, but not countrywide. One is that the epidemic phases are four. There is when there hasn't been a reported case in the country, and by this time, what the country can do is prepare and sensitize the population of the outbreak and the measures that will take place. For example, they will sensitize people about contact tracing, what it means to have be quarantine, what it means to have individual and community social distancing. This is when there is no case yet reported in the country. Now, there is when the epidemic is in its early stage of the outbreak. This is when you have one or more reported cases and there is limited local transmissions related to the imported cases. So here you conduct contact tracing, and then if there are limited cases, then you can easily know this case, which people have you met in the past 2 weeks, and then you can do contact tracing. And like I mentioned, you do contact identification, contact monitoring, and all the other steps, and then contact discharge. And then there is also where this it's no longer now an early stage outbreak, but now it's an expanding outbreak. And this is and here you get to realize that there's increased the number of imported cases. There is increased number of local. There's an increased local spread, but all these local spreads are linked to non-transmission chains. So when you do contact tracing, it still comes to to a case, So you still know where positivity is coming from, and also there are outbreak clusters with non-common exposures. For example, if this person went to stay in Nyamirambo and then he spent 3 days and then he moved to Chibagabaga, you can exactly know the reason why we are getting people from Nyamirambo is because one of the cases stayed there for 3 days. So you still know when there are outbreak clusters, you still know the common exposure. And then the only thing you can do here is you intensify contact tracing, and also you intensify adherence to quarantine as much as possible. But then there is where now it's no longer an expanding outbreak, but it is an advanced outbreak. You realize that there are so many local outbreaks that are starting to emerge, and then there is one or more cases of death outside the non-transmission chain. So this time you hear someone has passed, and this person is from Nyamagabe, and you wonder how this person reached Nyamagabe. It's an example I'm giving. Doesn't mean it has happened yet. And then also you find in the sustained person-to-person transmission happens in multiple generations. So you have a young adult, an adult, and an elderly, and they're all in the transmission chain. And then the only thing you can do here is you have contact tracing, and you you begin doing the delay and mitigation. Then mitigation, this is when you sensitize the population into social distancing, and probably you do lockdown. And then also in the first phase, when there's a large outbreak, mostly nationwide outbreak, is when you realize that the outbreak is nearly in all the country. So it wouldn't be wise to continue contact tracing because it's very expensive. So what you do here is you do social distancing and you do lockdown, which I think the RBC and the Ministry of Health are doing. I don't know if this answers the question of why in these last 2 months, RBC and the Ministry of Health has reduced making contact tracing. And then other question, if I have not answered, you can always like, there is asking, are we on phase 3 and 4? So looking at the numbers and looking at the responses that are being taken, we are on phase 3 and 4. Now the second question was family members, all positive, staying in the same house, interacting, yet having different levels of immunity, like those with weak immunity, who did not increase chances of weaker one getting worse. Now, I don't know how to clearly answer this question, but the best way to have the transmission of the spread of the COVID-19 is to isolate yourself during the 14 days. Now, if they realize that in a household, that the people in the household, all of them have a contact. Maybe they've had a contact with the person who has COVID-19. The best thing they can do is to have self-isolation. If any of the person becomes has symptoms, and then this person is tested, and if the person is tested and is positive, then the person is no longer a contact. The person becomes a case, and he or she is managed as a case. But the rest of the people, they remain in the isolation or in self quarantine at home. It does not necessarily mean that if you have weak immunity and your young brother has strong immunity, then maybe the person has strong immunity will give off the disease to the person has a weaker immunity. You all stay isolated and quarantined, and you can interact in that small space. If somebody develops symptoms of COVID-19, this person is tested, and if the person is confirmed to have positive 19, then the person is no longer considered as a contact, but as a case, and is managed as a case. And this can go on and go on to all the members who are showing symptoms. I don't know if the question has been answered. And then the other question is, why is it that after testing from contracting tracing, sometimes you're not given results? Now, I don't know if you've been, I don't know when you say sometimes, because I know most times when they do tracing, when they're doing community testing, they get your phone number, they get your location. So in case you're positive, they can begin tracing. So if they're not giving you, if they have not given you a result, maybe, I don't know, I don't know how to explain this, but usually you're supposed to get your results if you've been tested. It's like going to the hospital and you have signs of malaria and they test you and tell you to go and they don't give you anything. So ideally, you're supposed to be getting the results if you had the COVID-19 test. Then the other question is this self-quarantine, self-isolation, or home-based care feasible in the Rwandan context, whereby the promiscuity is very high, i.e. 10 people living in a house of 2 rooms. Is there any assistance provided to those people living in such conditions? So I think when we are doing contact evaluation and monitoring hierarchy, we said, like you're saying, it's not every Rwandan that would fall in this, but they characterized people in 4 priority cases. Now, the people who are like 10 people and living in a small house, they fall under priority 1. And these are the people who are quickly assessed, quickly monitored, quickly evaluated, and decisions are taken compared to people who are on priority 4. Now, I will go back through the people who fall in priority 1 and in priority 2, priority 3, and priority 4, so that you can know which priorities a lot of effort are put in. The reason why these priorities were put in place is because contact tracing requires a lot of resources, and at certain point may no longer contribute enough to the effectiveness of the epidemic control. To justify the resources required, it is therefore required to attempt to maintain follow-up. You cannot maintain follow-up of all your contacts because it can jeopardize the quality of contact follow-up. So you prioritize people depending on their priority cases. Now, patients who have been hospitalized, healthcare personnel, because they constantly meet or might constantly meet COVID-19 positive case, or first responders, like people who are in law enforcement and firefighters, individuals who are living or working or visiting acute care facilities, like people who are visiting mental health facilities and and skilled nursing. Individuals living or working or visiting communities in a congregate setting. For example, people are visiting prisons and homeless shelters, or people who are always in school, educational institution, these also fall in priority 1, Also, it also brings me to the question, members of large households living in close quarters, like you had mentioned, people were 10 and they're living in a closed house. And also individuals who live in a household with an individual at higher risk, or who provide care in a household with an individual who is at higher risk. All these people belong to priority 1. And if the tracer realizes you're in priority 1, the evaluation and monitoring starts straight away. But if a person, for example, is in priority 4, so this is an individual who has no symptoms and does not meet any of the above categories. Any of the above categories, that is, he doesn't meet these categories of priority 1, and he doesn't meet categories of priority 3. He's not above the age of 65. He's not at higher risk of severe diseases, or this person is not pregnant, and this person has no symptoms. So this person belongs to priority 4. So this person would be asked to self-isolate for 14 days, but the evaluation and monitoring will not be as intense as the person who belongs to priority 1. I hope that answers the question you had asked. Then I think this is there has been cases where confirmed COVID-19 cases were neither not being followed up, nor on daily basis, nor been apparently registered. What could have been the cause? Again, I am not sure of what could have been the cause of why certain cases were not registered or followed up. I don't know I don't know the reason why, so it's very hard for me to answer, but I would like to think maybe the human resource was limited, and maybe the follow-up was only done to people who were in priority 1 and priority 2, and people who belong to priority 3 and 4, the follow-up was not as intense as people who were in priority 1. But ideally, if the human resource is enough, like I mentioned, and then also people who fall in priority 4 and priority 3 are supposed to be followed up daily. But if they are showing no symptoms, and then after 3 days, again, a call is made or a text message is sent, and this person, the temperatures are normal, they're not showing any symptoms of COVID-19, usually like, to put resources to people who really need it the most, then they wouldn't be followed up like daily. I like to think this is the reason, but I'm not sure. And then the other question was, for the people in prisons living together, whereby new culprits are always brought in, isn't it easy for all of them to get easily affected? And this again takes me to the priority in evaluation and monitoring. So individuals who are living in or visiting community congregated settings, like correction facilities, these are prisons, homeless shelters, education institution, mass gathering, workplaces, belong to priority 1. And if a convict or a person in prison is a contact, then there is a lot of, the focus is channeled to this person. And then they have to see, is this person developing symptoms? If the person is developing symptoms, let's test this person. If the person has developed symptoms, but the test is still negative, the person continues to be followed up until day 14 when they do the last COVID-19 test. If the test is still negative, then the person is discharged as a contact and maybe can be treated for for the symptoms he has. If it is if they are flu-like symptoms, then the person is treated for flu. Yeah, but if the person is staying in a prison and then and is a contact and he develops these symptoms and the person is tested and this person that is tested is positive, then the person is regarded as a case and is managed as a COVID-19 case. I think, if I'm not mistaken, these are the questions that were asked.
Okay, thank you so much, Dr. Christian, for the lecture or course on contact. I'm sure we've been able to learn a lot from this. I would also like to thank Dr. Leonce, who has been helping us answer most of the questions in the chat. I don't know if there are any other questions from the participants or hands up because I didn't see any. We could wait for a few. If there are any more questions, and if there are not, we would like to thank Doctor again for the wonderful lecture and that we've really learned a lot from contact tracing and how it's done. Thank you so much for a very good presentation. And yeah, would also like to thank the participants that were able to attend. Thank you all for enrolling in and participating. Yes, thank you so much. It was really a great lecture. I think we'll meet tomorrow. We'll meet tomorrow same time for our last training on vaccines. And yeah, thank you so much.
Maybe before I leave, there are so many reading materials on contact tracing. You can check the CDC webpage. There is vast materials on it. There's also the African CDC. There is really constructive enlightening material on contact tracing. And they could help in answering some of the questions that you might develop later. Thank you.
All right, thank you so much. I hope you will all be able to check out the reading materials for more information and learning. Yeah, thank you everyone. See you tomorrow, same time, 2 p.m. For the last course.